Hi, this is Dr. Shorab. Today I am making this video for medicos, and my topics of today is atelectasis. I know it's familiar to you. The term is familiar to you. The term atelectasis. Atelectasis means collapsing of alveoli. The term atelectasis comes from the Greek word ateles and ectasis, means imperfect expansion. Just see that. Ateles ectasis means imperfect expansion. As if the term imperfect expansion of the alveoli is termed atelectasis. In ICU, we used to face this atelectatic problem of a ventilatory patient and non-ventilatory patient with having lung diseases. As if in medical intensive care unit or post-operative care unit, there are several patients suffering from this, and we have to identify those patients along with make some adjustment in ventilatory part and do something to reduce this complication. This complication is persistently seen to those patient will deteriorate and patient will go in respiratory failure. Firstly, I want to clarify this atelectasis process, how and when it happened. According to the process, it may be classified into three groups. One can be seen as let me make my board clear. The first cause we can say compressive atelectasis. In case of compressive atelectasis, when alveoli collapsed due to some external pressure, as if there is any tumor compressing the alveolus, or in the intrapleural space there is air or fluid, or if there is compression of the basal part of the lung from below the abdomen, if the abdomen is distended due to ascites or any kind of mechanical distracting conditions, when abdomen is distended and pushed the lower part of the lung, that also cause this kind of compressive atelectasis. Now comes to the second point, that is absorption in case of absorption atelectasis, absorptive process involved in this case. If there is partial obstruction or complete obstruction of an alveolus, the distal end, that gases diffuses to the blood and there is atelectasis of the alveolus. Or in case of mechanical ventilation, patients may have this kind of problem. Or if you give concentrated oxygen to those patients also undergoes this kind of absorptive atelectasis. And in case of post-operative period, when patient receives anesthetics, patient may undergo this kind of atelectatic problem. These are the basic causes of absorptive atelectasis, when lung collapsed due to absorption of the gas. And the third one, we all know, medicos, we all know that within alveoli there are always surfactants since birth. When we start our respiration, the gaseous exchange start. There is surface tension within that alveolus. This surface tension reducing substance is called surfactant. And alveoli cannot collapse due to this surfactant action. When these surfactants are absent or dysfunctional, patient may have surfactant impairment induced atelectasis. As premature birth, as seen is premature birth, there is low surfactant level or absent surfactant when patient needs surfactant from outside. And the other causes, as in ARDS or in several conditions where surfactant level are induced in acute lung injury, when you have to give surfactant from outside, which you usually gives DNAs, recombinant DNAs. This is the basic classification of atelectasis, how and when atelectasis occurs. With this regard, I want to say there are several classification and several modalities where we can classify this atelectasis, as we can say is as non-obstructive, obstructive, rounded atelectasis. In case of non-obstructive, we can say compressive atelectasis. That means, I have said previously, when the compression comes from outside, that alveoli collapsed. This is compressive atelectasis, where there is decrease of transmural pressure, decrement of the transmural pressure causes alveolar collapse. One is adhesive atelectasis. In case of surfactant reduction or dysfunctional, cicatrization atelectasis. In case of fibrosis, interstitial lung disease, replacement atelectasis in say case of bronchoalveolar carcinoma, there are several classification we can say in different views, that we can classify this as its different causes and procedures by which this kind of atelectasis occurs in those patients. This is obstructive type. I have said previously, when there is obstruction from the abdominal side, the mechanical obstruction, or outside there is intrapleural air or fluids, this is obstructive type. And in rounded atelectasis, it's seen in asbestosis. In this content, I want to say, here is middle lung syndrome. Here there is intraluminal and extraluminal obstruction. Of right middle lobe and lingula. It's very important in this regard of atelectasis. And in Sjogren syndrome also this kind of thing is seen. Just remember this, there is a syndrome called middle lung syndrome. There is obstruction of the intraluminal and extraluminal side. Now, these things I have said only the classifications and how atelectasis occurs from different disease processes. In this regard, I also want to clarify, in postoperative period, within 72 hours of postoperative period, patient may have, due to anesthetics used in ICU, in OT, patient may have atelectasis. This kind of atelectasis should be minimized by changing of posture, early mobilization, deep respiration, or use of incentive spirometry postoperatively. Usually, following any kind of upper abdominal operation or thoracic operations, patient may have shallow breathing, reluctant to change his position, and viscous secretion. To minimize this complication and make this patient comfortable deep breathing, we used to say or instruct those patient to mobilize early and have deep breathing exercise by incentive spirometry. What deep breathing causes in this patient, I want to make some diagram and clarify the situation, how we can improve this kind of patient by using deep breathing. Just say, deep breathing causes ciliary clearance of secretion, helps in distributing surfactant, redistribution of surfactant, and ventilation collaterals, makes ventilation easy to those alveoli. Ventilation collateral ventilations, I should say collateral ventilation. What is collateral ventilation? First, please remember these 3 points. With the help of deep breathing, when the patient has shallow breathing postoperatively, within 72 hours of this postoperative period or the perioperative period, patient may suffer from atelectasis and patients have hypoxemia. To overcome this situation, we need to instruct the patient with deep breathing or exercise, respiratory exercise, which is called incentive spirometric. By this, we can clear the secretions with ciliary clearance of the secretion, redistribution of surfactant throughout the alveoli, and collateral ventilations. If you assume here is a mucus plug. Air comes by this way. Here there is air. As there is mucus plug, air cannot able to come in this part, right? But if air comes in these directions, as there is block by mucus plug or thick secretion, if the air comes through this way, this part also aerated. There is also air in this part. What is called this thing? This is a alveolar septal pore of cones. Pores of in alveolar septa. With deep breathing, we can use this process. The air bypassed through this. There is no air in this route, right? There is no air. This is a collaterals of ventilations by which air can goes to these collapsed alveoli. With deep breathing, in deep breathing, we can do this and help this patient to make this atelectasis process to minimize, and the complication will definitely minimize. This is the basic thing I have said about atelectasis, right? But in patient having atelectasis, the common symptoms of atelectasis. Number 1, dyspnea. Number 2, cough. Number 3, patient may have fever or may not. Leukocytosis. And we have seen end inspiratory crackles. If you used our stethoscope in auscultation, we can see this kind of inspiratory crackles to this atelectasis patient. And what to do? In spite of instruct the patient having deep inspiration, incentive spirometric exercise. If patient persistently having hypoxemia in perioperative period, If the patient is in ventilation, if there is more than 50% or 50% above FiO2 and PO2 level persistently below 60%, this persistent hypoxemia cannot be improved by this kind of exercise. We have to give PEEP to the patient in ventilator patient. First, a few words regarding PEEP. PEEP means positive end expiratory pressure. In a normal spontaneous breathing patient, in respect to atmosphere, in the end of expiration, there is a pressure which equates atmospheric pressure. As we assume the atmospheric pressure with alveolar pressure is equal, and in this regard atmospheric pressure is 0, the alveolar pressure is 0. It is called JIP, it is not called PEEP. In case of spontaneous breathing in a normal person, there is interpleural pressure which is around minus 5 cm of H2O. Means alveolar to pleural pressure difference is 5 cm of H2O, which is enough to maintain at the end of expiration alveoli to be in full of air and the aeration process is maintained. But in case where elastic recoil of lung is more, the low lung compliance, increased work of breathing, ultimately those alveoli will collapse. Due to decreased compliance, increased recoiling forces of alveolus, lung alveoli collapsed. To minimize this complication, we used to give positive end expiratory pressure to those patients. And always remember, you should give up to 7. It's a physiological PEEP. It cannot reduce venous return to those patients. Why we think that increased PEEP can cause venous return? In case of increased PEEP, there is a pressure gradient. Basically, there is a pressure gradient between this pleural part and the right atrium, the pulmonary and right atrium. The venous return comes from the superior vena cava or the inferior vena cava. There is a pressure gradient. Through this pressure gradient, blood comes to the right heart. If the pressure gradients decreases, the blood comes from the superior or inferior vena cava will reduce. That those are venous return will reduce. As PEEP increased, the pressure gradient minimized, decreased, and the superior vena cava and inferior vena cava which blood returns to the heart, which also decreases. These are the venous return decreases. But within physiologic PEEP, we can say up to 7 cm of water, there is no decrement of venous return is seen. In case of ARDS and lung injury patient, acute lung injury patient, we can use PEEP. We have to use PEEP for refractory hypoxemia. Refractory hypoxemia. The main part we should remember when to give PEEP to this atelectasis patient. When there is intrapulmonary shunt or refractory hypoxemia, or there is decrease of compliance and reduced FRC, functional residual capacity, which is the summation of expiratory reserve volume and residual volume. In case of auto PEEP generation, there is air entrapping. There is increased residual volume, which volumes of lung cannot take part in ventilation. The normal range of FRC is 1.7 to 3 liter per minute. When this FRC reduced due to low lung compliance, there is increased work of breathing and patient may suffer from dyspnea or hypoxemia. To give PEEP to increase the lung compliance has increased the lung recruitment pressure, which causes increased FRC to reduce this kind of discomfort to this patient. And in persistent or this kind of refractory hypoxemia or intrapulmonary shunting procedure, we have to use this kind of PEEP to ventilate those patients and recover from the hypoxemic episodes. In ventilator, we have seen some graphical changes which are called the scalars. We can assume the patient is having low lung compliance, or the patient is having atelectasis process is going on. What are the changes in the scalars in flow part? Just say. Where we can see that there is triggering process going on, where we have to increase trigger sensitivity. We have to change this trigger sensitivity from volume to pressure triggering. When you see this kind of graph, this is sensitivity defect. We have to increase the trigger sensitivity and the volume sensitivity to the pressure triggering sensitivity and increment the sensitivity level to minimize this kind of problem. In case of low lung compliance, this is PEEP, this is PEEP, this is flat pressure. This difference, if this is PEEP minus P flat less than 10, there is definitely compliance problem. Reduced compliance seen in ARDS, edema, atelectasis, pneumothorax, effusion, if we put the tube in right bronchus, where compliance is the main problem, and in case of ILD, obesity, just remember those points where this compliance problem is seen. But when this PIP minus flat pressure more than 10 centimeter of H2, there is resistance problem. Resistance problem is seen mainly small ET tube, kinking of ET tube, obstruction, mucus plugging, bronchospasm, these are the basic conditions where resistance may increase. This part increased in this case. There is increment of this pressure gradient. This is the two things you should remember. The last graphical presentation in scalars, when there is this kind of graph, if you see the concavity upwards, this concavity upwards, this is over distension. This is over distension. But if the concavity downwards, this concavity downwards, this is upwards. Here, when it is upwards, there is stress index more than 1. Here, stress index less than 1. In stress index less than 1, there is increased compliance. And in more than 1, this is decreased compliance. In case of static compliance, the fixed inspiratory flow, when the lung is in static compliance, that is straight line, there is no deviation. This kind of deviation is seen. Here, stress index equal to 1. In this regard, just remember this kind of graphical presentation. When you see this kind of thing, this is over distension. And in ventilatory setting, when there is refractory hypoxemia, that is PaO2 more than or equal to 50 millimeter of mercury, in spite of giving FiO2 more than or equal to 50% This is 60%. 50% or more. PO2 is persistently low. Patient is showing refractory hypoxemia. What to do with ventilatory setting? In case of PEEP, if you increased PEEP, there is increased PIP, increased mean airway pressure, and if there is increased P plat. PEEP more than 50 centimeter of H2O, more than 30 centimeter of H2O, and this is also more than 30 centimeter of H2O. You should look for P plat. Once you increase PEEP, there is increment of peak inspiratory pressure, there is increment of mean airway pressure, and also there is increment of plateau pressure. When PEEP is more than 10 centimeter of H2O. But in case of ARDS, when you increase this PEEP, there is no relative pressure deviation or decrement of the venous return happen in this patient. We have to adjust by looking this plateau pressure also. These are all calculated figures. We can formulate this peak inspiratory pressure, mean airway pressure, or plateau pressure. We can figure out how we can formulate this and how we can formulate this. In case of mean airway pressure, which is very important, mean airway pressure. How will you figure out the data of mean airway pressure? There is a formula which is called Ti, inspiratory time, into PEEP plus expiratory time into positive end airway pressure by total cycle time. If you don't have this part, you can also deduct it by PEEP minus PEEP into Ti by total cycle time plus PEEP. There are several formulas to deduct those numbers to know what is the level of these parameters. And in case what to adjust in ventilation, you should look for two parameters. You know the patient's ideal body weight. You can make how much tidal volume you can provide by using 6 to 8 ml per kg. If within this tidal volume we can already given to your ventilator, you can increase the PEEP. Where you have made in between this parameter, where you can already adjusted your tidal volume and patient is still having hypoxemia, you should increase your PEEP by adjusting this. As FiO2 you can already increased and there is no result. I have said something regarding atelectasis and how to adjust it and make the patient comfortable in breathing part, and the refractory hypoxemia part, how you can improve the refractory hypoxemia. I think you will be able to adjust this kind of ventilatory part next time. In this regard, I think I have said enough. Thank you.